The next presenter is in my list is Professor Attila from the intensive care. Title is intensive care. I'm not sure because I'm sorry. So it was a change. That was a big problem. So people need the microphone to be. Change all that. So this is the way how the two centers try to work together. So, Attila is much more important than Laszlo. Attila, please. So your presentation is the Hungarian interventional radiological solution for hepato-pancreatico-biliary diseases.
Thank you, and sorry for the disturbances. We live in changing times, so thank you for the invitation. I will try to shed a light of mainly on the position of the Hungarian interventional radiology, and as Semmelweis University is one of the leading centers of it, then it will represent mostly the Semmelweis as well. What are the fields of the interventional radiology concerning the hepato-pancreatico-biliary diseases? So there are two main groups, vascular and non-vascular. In the vascular group, we can do dilatations, thrombolysis, stent implantations, cover filter implantation, embolization, TACI, CERT, portal hypertension management, so a lot of things. In non-vascular, we do biliary interventions. The whole is available, what is listed here. Even endoluminal biopsy is possible. We drain fluid collections. We do lots of types of biopsies, including transjugular biopsy, and we do a lot of thermo and chemical ablation. What is available in Hungary, which is a key question, and it will hopefully change a little bit time to time. So all the vascular techniques, including the radioembolization, is available in Hungary in several years at least. The problem is that there is a limitation in the number of the experienced interventional radiologists. Problem is with the reimbursement, of course, and the problem lays with the lack of widespread information. What can we do, at least? And of course, there are few centers, if there would be at all at one. With the non-vascular methods, the situation is, of course, very similar. Most of the methods are in Hungary, except the irreversible electroporation and focused ultrasound ablation. The IRI is coming to Hungary, hopefully in this year. Again, the same problems, limited availability, problems with the team decision practice, and the lack of knowledge of possible solutions. Let's focus on the vascular methods. All methods, as I said, are available. I didn't mention chemosaturation, which is a very specific tool, and it's not widely used throughout the world. Radioembolization is performed only at Semmelweis University in small numbers. Only some center performs a wide variety of treatments due to lack of experience and availability of IR specialists. TIPS and other interventions in the portal vessels are performed only in 2 or 3 centers. And transjugular biopsy is occasionally performed in the same 2 or 3 centers, but there's no reimbursement for that special biopsy, and it's costly. What about the thermal ablation? As a definition, we can treat any lesion which can be visible on imaging, and with the provision that there would be no harm doing this treatment. No harm would be caused to critical organs, vessels, or nerves. There are some tricks: hydrodissection, CO2 dissection, liver packing, and so on. So there are possibilities, and we can judge if there would be any safe possibility to treat a lesion. Chemical ablation is, of course, performed in, I don't know, 50 years. using usually in Europe the absolute ethanol. This is mainly works with small HCC. Thermoablative methods are, RFA, MVT, laser ablation works in a very similar way. The effect is very similar. The experience will just decide what to use and what not. As a good aim, we look for an A0 ablation, which would minimize the recurrence rate. And it means that the lesion size plus minimum 5 millimeter around. Again, there is a limited reimbursement. We can do this kind of treatment less than 10% of the European average, which is really a problem. And of course, for that, there is limited experience altogether. Biliary and fluid drainage is performed in several centers. Fluid drainage is most of the centers, of course. We prefer and we suggest to do ultrasound-guided puncture of the biliary tree with the so-called micropuncture access sets. This could really minimize the possible complications. As it was mentioned, the big problem can be treating the benign lesions, and for the vascular balloon dilatation, drug-eluting balloons are developed, and it can be used to treat benign lesions as well. There are tools for endoluminal biopsy. The problem is the same like in the transjugular. This is a costly device, and there is no reimbursement for that as well, but it is possible to do, and in some cases we can do it. There are some limited experience with endoluminal thermoablation. It's rarely performed, it's a palliative treatment, but it is possible, and we can do that if necessary. Most of the stent types, plastic or metallic, is available. There is no real experience, as far as I know, with biodegradable stents. And yes, there is some experience with endobiliary radiotherapy, which can be a good palliative tool. All kinds of fluid abscess, cellulosis, biloma, and so on. Drainage is widely performed using CT and or ultrasound guidance. There are some special tools for vascular treatments. There is a so-called EndoGuide used in DSA, using cone beam CT. There's a kind of a GPS using angiography, and the computer will show you where to go. It's a really nice tool. Other thing is for the fusion navigation using ultrasound. We can match the ultrasound images to a CT, MRI, or PET on the ultrasound machine, and the two will follow. I mean, the CT will follow the ultrasound image, and we can find the same lesion in ultrasound as in the CT. This is very useful in some cases. And there are some ultrasound machines which can provide this solution. There are many new so-called GPS guided or magnetic field guided, 3D guided tools. One of these IMACTIs, using a special device. You can, after doing a CT, you can do the puncture without using the CT time to time, so it will just decrease the X-ray time, which is very important for the patients and the personnel as well. This is our group using this device, and there is another one using volumetric planning and for ablation, for example. You can decide what kind of ablation method would you use. The system will know how much ablation zone it is necessary. It will tell you how many position you need for how long time, and after that it will just confirm the result of the ablation. So this is a highly precise method doing ablation in, for example, the liver. And I think it's very important when we try to focus on post-ablation recurrence rate. Some cases I will show small HCC for radiofrequency ablation. After ablation, the lesion size, the ablation zone is bigger. Let's say it's an A0 ablation. And for follow-up, the cirrhosis is going worse, but the lesion, this little scar tissue is treated well. This is a very good indication for such small HCCs. Another treatment for a colorectal solitary liver met, the small one. This is an A0 ablation. We did it with ultrasound guidance and show the images. In some cases, when comorbidities are a problem, this is a good solution for mechanical treatment of oligometastatic disease. This is a neuroendocrine liver met. It is difficult to see the somewhere here. And because of the size, we did a combined, this is for the ultrasound image, we did a combined embolization and ablation in the same time. This is the embolized vessel feeding the lesion, and this is the radiofrequency ablation needle. And the end result was really nice, so it's just vanished. It can be done. This is a patient with, sorry, it just goes. This is a patient with cholangiocarcinoma was operated on. The patient and the hepatopancreatico-biliary was performed. And after 2 years, there was an infiltrative recurrence disease, and liver abscess developed in the right lobe of the liver. We did a liver abscess drainage percutaneously, and then in all these cases, you might expect that there would be some problems with the anastomosis or the biliary drainage. Then after some drainage and flushing of the abscess, we could see that there is a connection with the biliary tree, and then puncturing the left side as well, and using the connection, we catheterized the right side, and finally we put 2 stents from the left and right in a kissing manner, and the end result was that. So this is possible. We can be asked to solve some problems, and we can think together to find solutions. This is a recent case with a bleeding into a pancreatic head necrosis. This is the extravasation here, and this is the angio image with microcatheter showing the fluid, the contrast extravasation there. We went a little bit further with the catheter to see there is no other site, and we put a lot of small coils, a so-called backdoor front door embolization to treatment. Some words about the tips. It is performed, as I said, 2 or 3 centers in Hungary. We have an experience we did for some 150 cases. These are the steps of the tips. Finally, there is a stent in the shunt after dilatation of the tract, and we can do some interventions in the portal system. This is a patient with chronic pancreatitis with a strictured portal vein and a lot of collaterals and bleeding from varices. Using the percutaneous method, we punctured the portal vein transhepatically, and finally we inserted the stent into the strictured portal vein, and this was solved by that. And in some cases, for lowering portal pressure, there is no other alternative just to do a partial splenic artery embolization. And finally, one difficult case with a patient with PBC on the waiting list and bleeding. There is no possibility for TIPS. Again, using the transhepatic portal puncture method, we just embolize these vessels with coils, and the patient has a new liver now. So in summary, in Hungary, there are positives. Almost every interventional method is performed. There is a structured learning programs which have started recently, and it results in an IR license, which is very good. The negative is that there are very few interventional radiologists, less than 50% than needed, and the service is highly inhomogeneous throughout the country, and there is really a lack of real centers. Thank you for your kind attention.
So we can state that the Center of Excellence of Interventional Radiology exists. So thank you. So we've got very good experience together last several years, and this is a very active and supervised way with interventional radiology, because we've got a lot of good interventional radiologists, but this way is absolutely excellent. Any questions?
So congratulations to this really very comprehensive arsenal of techniques. So my question would be, if I look at pancreas, and I know attending also plenty of European meetings, it seems for me, and worldwide meetings, that not only in Hungary the interventional radiologist number is low, but also it's a worldwide issue. And concerning the huge amount of technologies in the pancreas, what kind of evidence is current, or what kind of studies, which kind of great evidence is available, for example, which one, like thermoablation or the other techniques actually to use? Because what I see, this is more even like personalized issues for each patient, and not like global evidence-based like guideline, like as it was in the initiation. So in the initiative phase of pancreatitis. So how you can generate evidences for which technology to use in which patient's care, or maybe it's not necessary, just find the best solution for individual cases.
Thank you for the question. I think it's partly difficult, partly simple to answer, because as we work together, and we must work together, it means that there is a solution for every patient. It's a personal solution. So, to do a prospective study like double blind and so on, it's not really possible, I think, in cases of pancreatitis. But there is a lots of data already, as the previous speakers just stated, many of them, and most of the data works about the question that which is the more efficient way to drain these fluid collections. But still, all the options are there. So, and then we will go back to the decision patient by patient. So I don't think that in concerning pancreatitis, there is so much to do to decide what kind of percutaneous drainage would be possible, the largest bore, for example. But concerning the malignancies, there are results, and usually, which is a problem for interventional radiology, the cases for ablation treatment, for example, are usually the cases which cannot be operated for some reason. It means that most of these treatments are palliative treatments. So mainly cryoablation and irreversible electroporation is the main tools to treat otherwise irresectable pancreatic cancers due to any reason. And the results that there are some results, but it's not curing the patients.
This can, for example, because with pancreatic cancer, we know that the overall survival rate and the median they are very, very low. So these kind of palliative interventions can actually elongate both the survival for the patient.
Not the survival mainly, but the complications or the quality of life and so on. Yes, the pain. So there are some results about that, and for that reason, it is a good option, I think, for the patient.
Thank you very much. Any other questions? Thank you very much.